Aloha, welcome back to General Pharmacology. Let's move to the PowerPoint slides and get started with today's lecture. Today we're going to talk about gastrointestinal pharmacology, and then we're going to talk about asthma. So let's start out by talking about gastrointestinal pharmacology. The gastrointestinal tract has many important functions. One of them is digestion, digesting food. That's certainly an important function, and that's what we know of. However, it's also involved in something called excretory, endocrine, and exocrine. Can you know the difference between excretory, endocrine, and exocrine? All right, well, we'll start in the middle of the E words, the endocrine. Endo is putting a chemical, a substance, a hormone, into the blood supply to communicate with other organs. And so when we talk about endocrinology, we're going to talk about different organs that will put a substance into the blood so another organ can sense that chemical in the blood and make changes. That's endocrine. At the bottom is exocrine. Exocrine is local function, to where the chemical in the chemical that's released is intended for local area. And then excretory just means to excrete. That means taking something, making a substance, and putting it into a tube. And so make sure you know the difference between excretory, endocrine, and exocrine, because I think people think about it, they're not sure what the differences are. All right, well, the gastrointestinal tract has many functions and many disorders. There's a lot of tissues in the gastrointestinal tract that have we think of it all doing one thing, but there's actually a lot of moving parts to the gastrointestinal tract, and so there's just a lot of pharmacology involved in treating gastrointestinal disorders. That's why we've covered a lot of pharmacology before we even start gastrointestinal pharmacology. Today we're going to talk about acid peptic diseases. You might know them as gastroesophageal reflux and ulcers. That's acid peptic disease. We're also going to talk about nausea and vomiting. We'll talk about disorders of motility. Motility just means to move, and so when the bowel isn't able to push food through, we call that a disorder of motility. We'll talk about inflammatory bowel disease, and that's not to be confused with irritable bowel syndrome. And so both of those three-letter abbreviations begin with IB, and you'll hear IBD confused with IBS, and even though the letters sound very similar, the pathophysiology is very different. However, pain is still the common feature between the two. The stomach makes hydrochloric acid with a pH of about 3, some say 2, it's not really much less than 2. And the main purpose of that acidic secretion is to sterilize the food as it enters the body. As mammals developed, we ate a bunch of filthy things that we would not eat today, and so the stomach developed in mammals to create this acidic solution to sterilize the food. And so that acid's not really involved in digestion. That acid is involved in sterilization. Well, the acid's a good thing in normal situations. However, due to imbalances in the gastrointestinal tract, that acid can damage the esophagus, which is the food pipe leading to the stomach, and then the part of the intestine that the stomach drains, passes food into, is the duodenum. And so it's that stomach acid that can go up, affect the esophagus, as in gastroesophageal reflux. Reflux is just any time a fluid is moving in the backward direction as to what it's supposed to. And then the stomach acid can also affect the duodenum. All right, so the stomach produces a mucus that lines the stomach and protects the stomach from the acid. That's why the acid does not eat through the stomach, because this thick mucus lines the stomach and prevents that acid from eating away at the stomach. However, sometimes the stomach does not produce enough of this protective mucus. Usually that's due to stress, and sometimes that's due to medications as well. And so between stress and medication, that mucus lining does not form enough, and it gets thin enough to where the acid can start to irritate the stomach and eat away at it. So sometimes the stomach does not produce enough of this protective mucus, and this can be caused by stress. Right. So if we make more stomach acid than what the protective lining can handle, then we can end up with gastritis, erosions, and ulcers as well. And so I think we have some pictures of that. So if you go to the doctor's office, they might have this cartoon right here showing us the difference between erosions and ulcers. And so anyway, here's a normal stomach lining. In gastritis, when we do an EGD and an EGD is when we take a camera that looks like a little hose and goes down to the stomach, so we can take a look at the stomach, and we can see the duodenum as well. And when we see gastritis, we'll see these little red spots on the lining of the stomach, and so that's what I'm trying to show you with those little red spots there. And that can be painful. However, and usually with gastrointestinal problems, we usually have pain before we start having pathology we can see. Here the cells are being eaten away, but they've not actually gotten into the muscle layer of the stomach, and so we'll see erosions where that superficial lining has been eroded away, and then if it eats through the stomach lining and gets down into the muscular layers of the stomach, we can have ulceration. A certain part of the stomach is attached to our posterior wall of the abdomen, and so sometimes ulcers will not perforate the stomach, and so sometimes ulcers can perforate the stomach depending on their anatomic location. So some ulcers, because of their location, will eat through the stomach and cause a perforation and loss of stomach contents into the abdomen. Other ulcers will eat in a different direction and can cause bleeding and severe bleeding. And so whether it causes perforation or not depends on its location. All right, so sometimes the stomach acid is refluxed into the esophagus. And again, reflux is anytime peristalsis is moving something in one direction. If the contents move in the opposite direction than peristalsis, then we call that reflux. And so peristalsis moves food this way, and when acid and food move that way, we call that reflux, and we'll call that gastroesophageal reflux disease, GERD, and they talk about this during the drug company commercials. All right, and they'll call it acid reflux, gastroesophageal reflux disease, where the acid can bubble up through the stomach, and the main reason for that is something called a hiatal hernia. I think I have another slide on that. But our stomach, our valve between the esophagus and the stomach doesn't really exist. It's an anatomical feature that worked great when mammals walked on all four legs, and then once we started walking upright, that little valve quit working so well, and so the stomach can slide up and down and put acid up into the esophagus. And so when gastroesophageal reflux disease, reflux of acid into the esophagus is severe enough, then it can change the lining of the esophagus. And so again, it starts out as esophagitis, an inflammation, and we'll see red spots. And then we'll start to see erosions as it becomes more severe. Then this can form scarring and something called strictures, where the scar tissue can narrow the esophagus. It makes it hard for them to swallow. They get food hung up. That's called dysphagia or dysphagia. And then it can eat through the lining of the esophagus and cause ulcers. Something else that can occur is a precancerous metaplasia called Barrett's esophagitis, where if the acid continues to irritate the cells and continue to irritate the cells, then the cells will undergo a metaplastic change, and that can lead to a type of cancer. And so if you watch enough drug company commercials, they'll tell you your stomach acid can lead to cancer, but it takes a long time for this to happen. And then people in this situation, they have pretty severe disease, and so they're usually getting help before this happens, but that's something to keep in mind. All right, most of the time gastroesophageal reflux disease is caused by something called a hiatal hernia. A hernia is any time the bowel contents poke through a hole that they don't belong, and so we think of hernia as being down in the groin, but any time any part of the gastrointestinal tract pokes through a hole where it's not supposed to poke through, we'll call that hernia. And then the hiatal, hiatus in work, when you take a hiatus, it's like a vacation. In anatomy, a hiatus is an opening for something to pass through. And so on your diaphragm, you have this thing called an esophageal hiatus. That's that hole in the diaphragm where the esophagus will pass through. And so hiatal hernia is when the stomach will come poke up through the opening in the diaphragm for the esophagus. And that's where the word hiatal hernia comes from. And so this is the diaphragm. Up here we're in the thorax. Down here we're in the abdomen. Below the diaphragm is abdomen. Above the diaphragm is thorax. And here we see the stomach starting to poke its parts through the esophageal hiatus, resulting in a herniation of the stomach. And so that's why that's called a hiatal hernia. And it'll slip up and down. Some people can have it so severe in their stomach, can be so poorly attached that we can have lots of stomach up in the thorax. This valve right here between the esophagus and the stomach doesn't really function like a valve at all. It's very, very weak. When we walked on all four as mammals, then our junction between the stomach and the esophagus used to be bent over that hiatus, and so gravity helped this valve function. And then we got the wise idea of walking on two legs, so we can do more important things with our hands. And something that's happened is this valve doesn't function so well, and that's why hiatal hernias are so common, as is gastroesophageal reflux disease. All right, well, not only bothering the esophagus and the stomach acid can lead to ulcerations of the small bowel. That first part of the small bowel that the stomach feeds is the duodenum or the duodenum, depending on where you get your pronunciations. And so here, the liver would be up here draining bile, and the stomach has been cut away, and the stomach would empty into the duodenum. And this pyloric sphincter, now that's a real sphincter, that's a real valve. It opens and closes and works pretty well. And so our stomach, which is missing up here, empties food through this pyloric sphincter and into the duodenum. Notice the duodenum is where the gallbladder, or actually the common bile duct from the liver, drain bile into the small bowel. This is also where the pancreas drains its excretory enzymes into the small bowel as well, its digestive enzymes. So this is what's going on in the small bowel, and this is just supposed to give you a look at the duodenum. And so excess stomach acid coming down into the duodenum can cause ulcerations. And then here we see something, ulcerations caused by ZE. We'll talk about ZE. All right, ZE, Zollinger-Ellison, is due to tumors of the pancreas that secrete gastrin. So we talked about cancers, that when cancer is an abnormal growth of cells, and that abnormal growth of these cells, that dysregulation of their function causes them to secrete things that they would not otherwise secrete. And so the first thing you want to know about the pancreas doesn't secrete gastrin. Gastrin is secreted by stomach cells. When the stomach is stretched, it makes gastrin, and that stimulates gastric acid secretion. That's how it's normally supposed to work. In ZE, it's a tumor of the pancreas that begins to secrete gastrin. And this gastrin coming from this tumor signals the stomach to start making way too much acid. And that results in very severe acid peptic disease, gastric and duodenal ulcers. And so the reason we make this point is that when you look at H2 blockers and when you look at proton pump inhibitors, you'll notice that there's a specific dosage for Zollinger-Ellison syndrome. So that's what ZE is. And even though it's the pancreas that makes the gastrin, the pancreas is not supposed to be making gastrin. The pancreas does not make gastrin. It does that in this tumor, this neoplasm that we call Zollinger-Ellison. It can be very severe, and we have to be very aggressive about treating people with ZE. All right, sometimes peptic ulcer disease is caused by a bacteria called Helicobacter pylori, H. pylori, and so if you get an EGD, they'll do a biopsy and they'll test for Helicobacter pylori because this can be a cause of ulceration as well. All right, so the pharmacologic treatment of acid peptic disease involves several classes of drugs. These strategies will include using acid neutralizers, using drugs that decrease stomach acid production, using drugs that increase the stomach's protective lining and augment that, and then we'll also use antibodies for Helicobacter pylori. All right, antacids are weak bases that help neutralize stomach acid. And we'll divide them up. These are the typical bases that are used in antacids over the counter. Magnesium hydroxide, aluminum hydroxide, and then calcium carbonate and sodium bicarbonate. And the first thing I want you to realize is that these two are not systemically absorbed, but these two are systemically involved and absorbed. So when you take calcium carbonate or sodium bicarbonate, that can directly affect the acid-base balance in your body. Magnesium hydroxide and aluminum hydroxide are not absorbed systemically. They stay in the gastrointestinal tract, and so they can neutralize acid without changing the acid-base balance in the body. And so that's why usually the antacids will have a mixture of these, and so that's why these two got to be careful about taking too much of, because these will affect the acid-base balance. All right, the first thing I want you to know is magnesium has a laxative effect. Milk of magnesia is a laxative. Magnesium citrate is a laxative. Magnesium hydroxide is an antacid, and it has a laxative effect as well. And again, the magnesium hydroxide is not absorbed by the gastrointestinal tract, so people can take larger doses of those and not be concerned with affecting their systemic acid-base balance. But what I wanted you to remember is magnesium has a laxative effect. Aluminum, like aluminum bats, make things harder. And so aluminum hydroxide, it's not absorbed by the gastrointestinal tract either, but it has a constipating effect. And so this is important, especially when you take care of postoperative patients or anybody with some kind of bowel problem. And they're like, oh, well, I take this antacid at home. It really works for me. And something to keep in mind is this right here, that if they're in the hospital for some reason, they're in a clinical setting, and they're having loose stools, they're having diarrhea for whatever reason, and then they want to take the same antacid that they do at home, well, maybe magnesium hydroxide, an antacid with a magnesium hydroxide is not going to be very helpful for them if they're having loose stools. Maybe we would choose an antacid that has the opposite of causing loose stools. And then the opposite is important of somebody who's postoperative and they have slow bowel movements as it is. Maybe they have an ileus, maybe their bowels aren't moving, maybe they're on some kind of opiate analgesic that has a constipating effect, and then they want to take the same antacid that they do at home, and they're like, oh, well, antacids, then that's fine, they're over the counter, they're not going to have any effect over this. And that's not true at all. And so you want to keep this in mind, because when you're interviewing your patients about the medications they take, we won't even talk about antacids because they're over the counter, they're not drugs, and nobody really cares. And that's not true, because a lot of people have really bad acid peptic disease, and they eat this stuff like candy. And so this can have an effect between the magnesium or the aluminum. This can have an effect on their bowels. And so you're going to know that when you talk to them, when you ask them these questions. And then in the clinical setting, we can use one or the other depending on what overall effect we want. And so no, not all the antacids are exactly identical to each other, and each one says it's better than the other one for whatever reason. But this is a pharmacology class, and these different medications have different uses, and so we can think about that when we're using antacids, especially in a med-surg situation. All right, well, calcium carbonate and sodium bicarbonate, not only will they neutralize the stomach acid, however, they can be absorbed systemically. And so people who take too much of these, they can affect their acid-base balance, cause a metabolic alkalosis from the excessive use of these. All right, strategies for treating acid peptic disease include treating stomach acid production. And so the two classes of drugs that we're going to use to decrease stomach acid production are the proton pump inhibitors. Remember, protons are hydrogen ions, and anything that releases hydrogen ion into the water is an acid. And so your stomach has these little pumps that will pump hydrogen ions into the stomach, creating this acid. So we can use drugs that block that from happening. Those are the proton pump inhibitors. All right, well, histamine is a neurotransmitter that's used to stimulate stomach acid production in the gut, and those receptors that sense to histamine are receptor type 2, histamine receptor type 2, and so we'll call these histamine receptor type 2 antagonists, H2 blockers. Again, this H in H2 blockers has nothing to do with the H that's a proton, and so that's a favorite trick question. But again, the two main drugs we use to decrease stomach acid production are the proton pump inhibitors and the H2 blockers. All right, so these are the more modern, common ones used, and you can look at the list, and they talk about these on TV all the time as if they're all just completely different from each other. And if you read very carefully, some of them are just prodrugs of the other. And so once these drugs make a first pass effect from the liver, you end up with exactly the same medication. Let's see here. When somebody's admitted to the hospital, we'll put them on a proton pump inhibitor. Why? Because being in hospital is very stressful for the patients and pretty much everyone else, and that stress decreases stomach acid, decreases the stomach lining, and so people would get ulcers when they're in the hospital waiting for whatever. And so you'll see it's routine if a patient is expected to stay in the hospital more than a few days. We'll put that on a proton pump inhibitor to prevent stomach acid secretion. In the old days, we used a lot of H2 blockers, and then when they came out with the proton pump inhibitors, they said, oh, well, we're never going to need H2 blockers ever again, and that's not the case. We still have uses for Tagamet, Pepsid, Axid, and Zantac. One of the manufacturers of Zantac, there's been a byproduct in it, and so it's been getting some bad press lately. But these are the H2 blockers. Let's see. So something else to keep in mind that's very important to know about the proton pump inhibitors is we will take patients who have intractable nausea and vomiting, or for whatever other reason, we'll put a nasogastric tube. We'll put this tube into their stomach, and then we'll attach that to vacuum, and we'll start pulling the contents out of their gastrointestinal tract. And one of the things that we do when we pull the stomach contents out of the patient is we're pulling acid out of their body, and if we don't do something about that, then they're going to end up with metabolic alkalosis. And so there have been countless times where I was asked to see a patient to figure out why they had very significant metabolic alkalosis. And it's because nasogastric tube, when a nasogastric tube is in a patient and we're pulling the stomach acid out of them, they end up with metabolic alkalosis. And so anytime we put an NG tube in somebody and we're going to put it on vacuum and pull out their stomach contents, to avoid the patient ending up in metabolic alkalosis, we're going to start them on a proton pump inhibitor or an H2 blocker, depending on what your hospital policy is. A lot of these are oral medications that you can get over the counter, and then things like Pepsid and some of these medications are available. Prevacid and Protonics, I believe, are available IV in the hospital setting. So keep that in mind. When I was a resident, we didn't have these, but we had plenty of Pepsid in one of our jobs, just to make sure that everybody in the hospital that ever came in, we wanted to give them IV Pepsid, and then we also wanted to give them subcutaneous heparin so they would not develop deep vein thrombosis, because in the old days, many patients, one of the big problems they'd have with iatrogenic problems, iatroself-genic to form, was stomach ulcers and deep vein thrombosis. Something else you want to know about these drugs is they can interfere with calcium metabolism, and they can significantly contribute to osteoporosis, and then there's something called osteonecrosis of the jaw as well. And so look out for the warnings of how these drugs interfere with calcium metabolism, because I don't talk about it today, and keep things moving here. All right, one of the strategies in acid peptic disease is to protect the stomach lining. And so we can use sulcrafate carafate to treat the stomach lining. Sulcrafate carafate can come as a liquid that you can just drink. It also comes in these tablets, and they call it a slurry because you're supposed to take the tablets and put them in a little solution of water, a couple ounces of water, and drink that. I've heard plenty of people say that sulcrafate isn't very good for protecting the stomach lining. Ooh, that was interesting. But sulcrafate does have protective function that we can use in peptic ulcer disease. Pepto-Bismol used to be the answer for everything back in the old days before all the rest of the medications came up. And the colloidal bismuths do have a protective function, and they are also very useful in treating. In the old days, we used to use that to treat Helicobacter pylori. And so a lot of people, when they have H. pylori infections, maybe they're non-compliant, maybe they're not able to tolerate the medication. And so the use of colloidal bismuths was certainly more common for that in the past. But you'll see the commercials, Pepto-Bismol used to protect the stomach and relax it. But it has more interesting uses than just that. Cytotec, misoprostol, is a prostaglandin, and so it can be used to increase mucus production of the stomach. However, this drug is contraindicated in pregnancy. This is a known teratogen, so we have to be very careful using this drug in women of reproductive age. Well, then they have antibiotics that we can use for H. pylori, the tetracyclines, metronidazole, which is Flagyl. Flagyl is the antibiotic, and we'll talk about this later, that causes a severe reaction in people who drink it usually within 12 hours, even 48 hours of drinking alcohol. And so when you look at this drug label, you'll see this is the drug. This is the antibiotic. They say if you take this with alcohol, you'll get this disulfiram reaction like antabuse. They give it to alcoholics to discourage them from drinking because it'll cause nausea and vomiting with alcohol. And the same reaction occurs with Flagyl, metronidazole. Amoxicillin can be used to treat H. pylori. Clarithromycin, which is Biaxin, is more commonly used to treat H. pylori. But again, the macrolides, this antibiotic class, can cause nausea and vomiting in people as well. And so between and usually we choose two different types of antibiotics when we treat H. pylori if it's severe enough. And so between that and the proton pump inhibitors they have to take with it, it's very difficult to treat H. pylori, and they have to take the medications for a long time. 6 weeks is pretty normal for the treatment of H. pylori, and so it's hard to get people to be compliant with this. I think I mentioned this, the colloidal bismuths do have antimicrobial properties, and so I'm a big fan of Pepto-Bismol for all sorts of reasons. Let's talk about nausea and vomiting. Drugs that prevent vomiting are also called antiemetics. Emesis is vomit, so antiemetics prevent vomiting, and then they prevent nausea as well. And so we call those the antiemetics. And we'll divide them up into the serotonin antagonists, the phenothiazine-based D2 antagonists, the antihistamines, antimuscarinic agents, and then the cannabinoids. Cannabinoids are the active ingredient in marijuana. So we talked a little bit about ondansetron in the serotonin section. Again, it was originally indicated for cancer chemotherapy. However, it is safe to use in children and adults. And now they have something that can go in the mouth and immediately dissolved. And so this has taken away the need for a lot of suppositories that we used to use when people had a lot of nausea and couldn't take the medications. All right, the D2 antagonists, Reglan, Compazine, Phenergan, and Napsine. Compazine and Phenergan you're going to see used most commonly, Reglan as well. Something to keep in mind, though, is these are based on antipsychotic agents, and because they're based on the antipsychotic agents, we need to be on the lookout for them causing dystonic reactions, and we need to be on the lookout for them causing orthostatic hypotension as well. A much bigger problem with this using Reglan in the elderly, getting the central nervous system effects than younger people. So be on the lookout for the use of these medications and some of the unwanted effects that result from their D2 antagonism. Now, something interesting, though, is that we can use this medication for nausea in combination with other drugs in a different class, in a non-serotonin class, and get more control over nausea and vomiting. And if you're in the cancer and chemotherapy business, you'll get to learn all about that. Antihistamines have antiemetic properties, and that has to do with their central nervous effect, not only on histamine receptors, but their antimuscarinic effects as well. And so you'll see all of these drugs listed as antiemetics, and in the previous lecture we just talked about how the older antihistamines have a lot of mixed actions, especially on the central nervous system. The newer H1 antagonists, the newer antihistamines, they're not going to have antiemetic properties because they don't have the central nervous system effects. But Benadryl, meclizine are old antihistamines that can be used as antiemetics. Antimuscarinics like scopolamine, they're used for, it's a little patch. You'll see people, they put a patch behind their ear for motion sickness, and that's an antimuscarinic agent that is also listed as an antiemetic. And then Dramamine. Dramamine has not only antihistamine properties but antimuscarinic properties, and Dramamine is available over the counter for motion sickness and nausea. And so because the older antihistamines have so many different properties, not only antihistamine but anticholinergic effects, when you look at a drug guide, sometimes you'll look at one drug guide and it'll say one thing, you'll look at another drug guide, it says something else. And that's just because of the complexity of the antihistamines and their anticholinergic properties. All right, remember the parasympathetic nervous system is the rest and digest system. It was acetylcholine that stimulated digestion. And because the parasympathetic nervous system uses acetylcholine as the neurotransmitter, anticholinergic agents like muscarinic antagonists will slow the gastrointestinal tract. And so the belladonna alkaloids, atropine is a belladonna alkaloid. It's an antimuscarinic, anticholinergic, parasympatholytic, and it can be used to treat nausea, vomiting, and diarrhea, because diarrhea is a hypermotility of the gastrointestinal tract. And so because because acetylcholine speeds that up, atropine can slow that down. The cannabinoids are the active ingredient in marijuana. They can take this and put this in a pill form. I'm not sure if these are even available anymore. The use of cannabinoids is kind of more out of the pharmacology section and more towards the natural health section, and so we don't really have a lot of pharmacology to talk about in the cannabinoids, other than what you see out in the lay public. All right. All right, the motility disorders are disorders of movement, basically movement of contents through the gastrointestinal tract, disorders of peristalsis. Paresis means weakness. Plesia means complete paralysis, and so you'll hear this paresis word used in the gastrointestinal tract. Gastroparesis just means a weakness of the ability of the stomach to move, and so gastroparesis is a motility disorder. And something that should be in great big print right here is diabetes mellitus. It's a disorder of glucose regulation, and one of the first things that diabetes does is affect nerves. And the first place we notice that is like on the toes. We can do this little test to see that the diabetes affect their sensory nerves. But something we forget is that diabetes also affects the nerves in the abdomen and the thorax as well. And so it affects the nerves that the patient relies on to move food through their bowels. So the peristalsis system is affected by diabetes mellitus. And so one of the major problems with diabetes mellitus is gastroparesis. Other degenerative neurologic disorders, pretty much any neurologic disorder, if it goes on long enough, can cause motility disorder through gastrointestinal paresis. Ileus is usually post-surgical. Ileus is a failure of a peristalsis through the gastrointestinal tract. And not only will fluid collect in the gastrointestinal tract, but gas will collect in the gastrointestinal tract as well, causing them abdominal distension and eventually pain. So because acetylcholine is used by the parasympathetic nervous system to stimulate digestion and stimulate peristalsis, we can use cholinomimetic drugs to stimulate movement, and we'll call them prokinetics, kinetic meaning to move. And so drugs that increase motility are called prokinetics. Bethanechol is a prokinetic because it is a muscarinic agonist, and we talked about bethanechol when we talked about autonomic pharmacology, and then we talked about the stigmines as well. They are cholinesterase inhibitors. Remember, acetylcholinesterase breaks down acetylcholine, so by inhibiting the breakdown of acetylcholine, we end up with more acetylcholine in the synapse, and so that's how the stigmines, so the cholinesterase inhibitors, are cholinomimetic drugs. And so you'll also hear those listed as prokinetics, meaning increase the motility of the gastrointestinal tract. Cholinomimetics stimulate the gastrointestinal tract and are used as prokinetics. I think we mentioned that. Reglan also is a prokinetic drug, and then remember we just talked about it being a D2 antagonist as well. And so be careful using Reglan, especially in the elderly population, because of its effects on dopamine. We can have orthostatic hypotension, dystonic reaction, and then because of its effects in the central nervous system, we can have behavioral effects, especially in the elderly. That's my anecdote from using it and seeing it used in the clinical setting. All right, let's talk about inflammatory bowel diseases. Inflammatory, as in inflammation, these can be very severe when the inflammatory processes in the bowel can be so severe they can inflame and actually eat through and destroy the gastrointestinal tract. And so inflammatory bowel diseases can lead to not only abdominal cramps, pain, diarrhea, and weight loss, and bleeding. That's one of the essential features of inflammatory bowel disease that separates it from irritable bowel syndrome especially. But the inflammatory bowel diseases can result in death. There's an entire spectrum of inflammatory bowel diseases if you read this very carefully, and people on one side of the spectrum will call that Crohn's disease, people on the other side of the spectrum will call that ulcerative colitis, and then we divide those features up and consider them to be completely separate diseases. However, you will see people with inflammatory bowel diseases that have a little bit of a mix between these two. Again, these can be life-threatening disorders, especially Crohn's disease. Crohn's disease can be so severe that it'll destroy the gastrointestinal tract and lead to death. All right, the main things that we use to treat inflammatory bowel disease are immunosuppressant agents. And so some of these drugs that we're going to use to treat inflammation are also going to be used to treat cancer. And And so don't be surprised if you see these inflammatory drugs, these anti-inflammatory drugs used in different settings, like arthritis. One of the major drugs used in arthritis can be used in Crohn's disease as well. Azathioprine, 6-mercaptopurine, methotrexate. These are going to be used as cancer chemotherapeutic agents. They can be used as, methotrexate especially, can be used in rheumatoid arthritis. And here we're using the medications as immunosuppressants and then anti-metabolites. Basically, these interfere with the formation of the purines, and these interfere with the formation of nucleotides. That's what I'm trying to say. All right, and then there's anti-tumor necrosis factor alpha. All right, so your body has this thing, makes this stuff called tumor necrosis factor, and we're going to talk about this in immunology. Your body has this natural system to destroy tumors. Your body is always making these little cancers, and your immune system is really good at fighting them off and dealing with them before they get out of control. And so your immune system is designed to deal with neoplasms and has this natural occurring substance called tumor necrosis factor. And so we use drugs that interfere with the receptors of the tumor necrosis factor, and these can be used not only with inflammatory bowel disease, but severe rheumatoid arthritis as well. And so infliximab, Remicade, is a tumor necrosis factor, an anti-tumor necrosis factor, and we'll see these drugs used more when we talk about immunology, and then we'll start talking cancer and chemotherapy. The first thing I wanted you to see with that MAB word, any generic term that ends in MAB means monoclonal antibody. And so we're going to talk about that more when we talk about immunology. We can use the aminosalicylates. We're very similar to aspirin, although the aminosalicylates are in their own class, and these are prostaglandin inhibitors as well. And you can take a look at these drugs. They're used to treat inflammatory bowel disease as well. But do not confuse the inflammatory bowel diseases with irritable bowel syndrome. The abbreviations are very similar, but the disease processes are very different. Irritable bowel syndrome is much more difficult to explain from a pathophysiology point of view. However, stress and behavioral problems, disorders of mood, certainly contribute to irritable bowel syndrome. And people who have irritable bowel syndrome, they have pain, bloating, and discomfort. That's why they're confused, because we'll see this with inflammatory bowel disease as well. However, the symptoms vary from male to female and vary from person to person. And so the old descriptions are people with irritable bowel syndrome, they'll have constipation for a few weeks and then diarrhea for a few weeks, and it'll go back and forth. There are people who always have constipation with their irritable bowel syndrome. There are people who would always have diarrhea with their irritable bowel syndrome. Sometimes people find that their symptoms are continuous and never go away with help. Other people, their symptoms can come and go. Stress is a contributing factor in irritable bowel syndrome. That's why psychosocial support is essential with irritable bowel syndrome. And then dealing with any kind of gastrointestinal problem is essential in dealing with irritable bowel syndrome as well. Something unique about something to differentiate irritable bowel syndrome from the inflammatory bowel diseases is irritable bowel syndrome will not result in blood in the stool. All right, the drugs that have been traditionally used to treat irritable bowel syndrome, they come on the market, and then they take them off the market, and then they come back on the market with special uses. That's why I want you guys to look this stuff up, because like this drug, Lotronics, Alocitron, it was on the market, and then it was off the market, and then it came back on the market with very special uses. And so that's something we want to cover in the clinical discussion section. But it was one of the first irritable bowel syndrome medications used for people who had irritable bowel syndrome that was predominantly diarrhea, especially women. Tegaserod, Zelnorm, I've seen this work in plenty of people really well. It worked for irritable bowel syndrome. when their predominant symptom was constipation. Against it was on the market, they took it off the market, they brought it back to the market under special circumstances, and there are other drugs used to treat irritable bowel syndrome now. But notice the difference between the serotonin receptors. Same problem, different receptors. So the serotonin receptors, like we discussed, it gets really complicated keeping track of which receptor does what and where. All right, one of the things we can use to treat irritable bowel syndrome are the anticholinergic drugs. Remember, acetylcholine stimulates the bowels as part of the parasympathetic nervous system, so using drugs that block acetylcholine can decrease stimulation of the stomach and the gastrointestinal tract and help with irritable bowel syndrome. So hyoscyamine is Levsin. It's available in a BID form, also known as Levbid. It's an anticholinergic drug. It's used to treat irritable bowel syndrome as well as other things, other gastrointestinal problems. All right, well, hopefully we have enough time to do asthma. In the old days, the gastrointestinal tract. The GI Pharm lecture lasted a little longer, and then I had the privilege of giving a lecture for the American Lung Association, trying to educate people on how to educate people with asthma. And so this lecture is based on a short lecture I gave for the American Lung Association. Right. So asthma is a chronic inflammatory disorder. Inflammation means the immune system is involved, and we will talk about that when we talk about immunology. Chronic means it goes on over time, and it involves the airways. And so asthma is like an allergic reaction with your lungs. You know, when you have an allergic reaction on your skin, we call that contact dermatitis. When your lung is having the allergic reaction, we call that asthma. So you'll hear asthma called reactive airway disease, and that's fine. When you hear somebody say reactive airway disease, we're talking about asthma, but there are other reactive airway diseases as well. Asthma is certainly the major one. However, there are people with chronic obstructive pulmonary disease that can have a reactive airway component to their disease as well. But for the most part, when you see reactive airway disease, people are talking about asthma. And again, this is an inflammatory reaction to coming in contact with something that causes mast cells to release histamine and leukotrienes. Broncho, as in lung airways, spasm, to close, bronchoconstriction is the same thing as bronchospasm. It's the clinical manifestation of asthma. And so clinical manifestation, that means there's something going on at the cellular level. It's like, well, great, I don't have a microscope. How am I going to know? Well, then the clinical manifestation is, well, all this microscopic stuff results in this. And so bronchospasm is the clinical manifestation of this inflammation, and that results in coughing, wheezing, and poor gas exchange. The first thing I want you to know about an asthma and wheezing is we think the louder the wheezing, the worse the asthma. And that's fine, but if you think about a little musical instrument like a recorder or a flute, it makes a louder noise when you blow through it harder. However, you can blow so little air through the flute that it doesn't make any noise at all. And so we think clinically more wheezing means more asthma, and that's fine when you're learning, but in a clinical situation, somebody can have really severe asthma, and they can be having a severe asthma attack, and they're not making enough wind to make the flute work, and so maybe they won't have as much wheezing. So be careful with this wheezing. Think of it as a musical instrument that you blow air across to make noise. And then obviously the coughing is a problem, and then poor ventilation. They're not able to move gas in and out. They're not able to move air in and out of their body. They're not able to get the oxygen in and the carbon dioxide out. All right, so these mast cells release histamine during an allergic reaction during a reactive episode. That's why it's called reactive airway disease. And this is a major problem for asthmatics, resulting in bronchoconstriction, constriction of the lung airways. Leukotriene D4 is also released by the mast cells and creates a major problem for asthmatics because it sets off this inflammatory cascade, and that clinical manifestation is bronchoconstriction, coughing. All right, cholinergic drugs, drugs that mimic acetylcholine are a major problem for asthmatics. And maybe the slides are in here. But remember your parasympathetic system, your rest and digest system, one of the things it does is narrow lung airways and make them wet because your body believes that if you're resting, that you can filter the air better. That's the strategy that's involved in that physiology, is to narrow lung airways and make them wet so we can not only filter better, but engage in something called pulmonary toilet, where we can get dirt and other toxins in the lung airways. We can toilet them out. We can cough them up and either swallow them or spit them out. It's called pulmonary toilet. And so that's encouraged by the parasympathetic nervous system, which narrows the lung airways and makes them wet. All right, so that's fine in a normal person, but an asthmatic, they can't tolerate narrow airways and wetter airways. That just makes the situation worse. So drugs that mimic the effect of acetylcholine are problematic for asthmatics, resulting in bronchoconstriction. All right, remember it's beta receptors that open the lung airways. So beta blockers, which are commonly used to treat high blood pressure, can narrow lung airways. And just like cardioselective beta blockers, see, I knew I had a selective example. Cardioselective beta blockers can still cause bronchospasm. There's things out there that, oh, well, they're selective for the heart, so they don't affect the lungs. And that's not true at all. If you actually read the drug label for cardioselective beta blockers, they can be a problem for asthmatics as well, and anybody who has a reactive airway component to their pulmonary disease. So we have to really be careful about using beta blockers in people with reactive airway disease, especially asthmatics. And even the choice of cardioselective, and again, that's where that selective word isn't a very good choice, because the cardioselective beta blockers are more selective for the heart, but they still have an effect on the lungs, causing bronchoconstriction and cough. And so histamine, leukotrienes, cholinomimetics, beta blockers, some of the things that are problems for asthmatics. All right. The most important thing we can do to teach our patients about how to use their medications is to divide them up between the rapid-acting inhalers and the long-acting inhalers. And again, when I took care of patients, I would like them to bring their medications in, especially asthmatics. Difficult to control asthmatics. I always wanted them to bring their inhalers in so we could make sure that they had a very clear understanding of how the different inhalers work. Because I'm going to spend a lot of time and a lot of PowerPoint slides explaining it to you. It's really very difficult to explain it to a patient, and then they go to the pharmacy and they get this 5-page thing. And I assure you, not too many people read that. And so it's very important that we teach our patients the correct use of the inhalers, because each of them have a little bit different use and a different indication. And so the first thing we want to do is divide our inhalers into rapid-acting inhalers and then the long-acting inhalers. And the rapid-acting inhalers we can use while they're having an exacerbation of the asthma. Something's happened, their lung airways are reacting, they're having coughing, poor gas exchange, and wheezing, and we need something that's going to rapidly act to treat them right then and there. Well, then there's long-acting inhalers that are used to prevent that from happening, and that's certainly not what we want to use during an asthma attack. What we want to use during the asthma attack is a rapid-acting inhaler. And the rapid-acting inhalers, and we'll come back to this, at the bottom line, the rapid-acting inhalers, you'll also hear them called rescue inhalers. Albuterol is a short-acting beta-2 agonist. We talked about that in the autonomic pharmacology section. And then ipratropium, you'll see that little atropine word there. It's an anticholinergic synthetic form of atropine. It has anticholinergic properties. And so these are our rapidly acting inhalers. The American Lung Association believes that ipratropium and albuterol are both equally rapid-acting inhalers. There are other people who, well, it's not quite as rapid and doesn't have quite the rapid-acting rescue ability that albuterol does. So that's why albuterol is in larger print and ipratropium is in finer print. But these are both very efficacious, very useful rescue inhalers, rapid-acting inhalers. And then we're going to talk about the long-acting inhalers that are not used during an asthma attack. The glucocorticoids, the long-acting beta-2 agonists, and then the mast cell stabilizers. All right, so this is basically the 5 classes of drugs we're going to talk about today. The rapid-acting beta agonist, the short-acting, rapid-acting anticholinergic, and then the glucocorticoids, the corticosteroids. They take longer to work. We'll talk about the corticosteroids when we talk about endocrinology in our next set of lectures. And then we're going to talk about beta-2 agonists and mast cell stabilizers. Again, these are called maintenance inhalers because we use them on a regular basis. They can prevent exacerbations of asthma. All right, so again, for the quick release of bronchospasm, we will use short-acting beta-2 agonists, and that'll be abbreviated. Something we like to do in medicine, something other people like to do in medicine, is make these abbreviations. They try to abbreviate everything, like SABA is so much easier to say than short-acting beta-2 agonist. And something I want you to realize is that need to make shortcuts everywhere in our speech. I think that results in this shortcut philosophy in our brain where we're always looking to cut corners. I thought it was interesting the other day, somebody came in the room and they said, "Oh, I want the usual." Like usual is so difficult to say that they can't say usual. They say, "Oh, I want the usual." And that's cool and it's fun and it adds a little spring in the step of the day. But I think it trains the brain to always be looking to cut corners and make shortcuts and not complete a thought or a sentence or a word. And so something that I would ask you to do in the clinical pharmacology section, especially to prevent confusion, is to go ahead and pronounce things and not use all these TLAs, 3-letter abbreviations and 4-letter abbreviations and 2-letter abbreviations. So the American Lung Association, they like to throw the word SABA around. And for those of you who know where Ozzy Osbourne came from, we just prefer short-acting beta-2 agonists. It's not hard to say, all right? All right, so the short-acting beta agonists are sympathomimetic. They mimic the effects of adrenaline, and we talked about that in the autonomic nervous system. And if you remember, epinephrine, adrenaline, and any sympathomimetic drug that affects beta agonists or beta-2 airways, and it's going to open them up. All right? So epinephrine and the sympathomimetics are bronchodilators. They relax that smooth muscle around the airways, causing them to open. And so that's why drugs that are used as rapid-acting inhalers are also called bronchodilators, dilate to open. And so albuterol is our rapid-acting beta agonist because it's a bronchodilator. All right, in the old days, we called the rapid-acting inhaler, oh, that's your little yellow, oh, that's your little yellow inhaler, your little yellow rescue inhaler. I saw that the other day in something. It was like, oh, the little yellow rescue inhaler. Well, the problem is there's little gray rescue inhalers and little red rescue inhalers and little blue and red rescue inhalers. So the days of the little yellow rescue inhaler are gone. And something that I would ask people to do is, you know, we explain all this to our patients. We don't do a very good job because we don't use a lot of PowerPoints. And then look, the name of the drug is teeny, 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 tiny. And so there's no way that you're going, oh, well, use your Provenal. Well, which one's the Provenal? I can barely see that. And most of your patients, they can't read the fine print either, especially if you talk in generic terms. The generic is so tiny that no one can read it. And so sometimes it's helpful to write with a Sharpie on the medications so that the patient knows which inhaler they're supposed to use. Because one of the most difficult things with taking care of patients who use inhalers, they don't know which inhalers for what, and so it's really hard to get compliance. And so albuterol as Provenal, albuterol as Ventolin, albuterol as ProAir, these are all excellent for the quick relief of bronchospasm, and so these are short-acting beta agonists. All right, the leva means it's the left-handed version rather than the racemic versions. So it's called Xopenex, and it is going to be a little bit more efficacious than the other forms of albuterol. But again, it's a short-acting beta-2 agonist used as a rescue inhaler. So make sure that you know all of these are basically forms of albuterol. This is a special form of albuterol with the right-handed versions fractionated out. So make sure that you know the short-acting beta-2 agonists. Make sure your patients know the short-acting beta-2 agonists, that those are the ones that they can use as a rescue inhaler to use when they're wheezing. And then we can use an anticholinergic drug as well. And again, acetylcholine narrows the lung airways, makes them wet to improve filtration, but that can be problematic in asthmatics. And so acetylcholine is a bronchoconstrictor. The cholinomimetic drugs are bronchoconstrictors, and that's especially a problem with an asthmatic. And so that's why we use anticholinergic drugs as bronchodilators. Let's do that again. We use anticholinergic drugs as bronchodilators because they block that constriction system from the parasympathetic nervous system. And so you'll see that little atropine word in there, atro. There's atropine again. Atrovent is the anticholinergic drug that we can use as a rapid-acting inhaler, but the manufacturer insists that the relief is slower, and so then you'll hear a debate, especially in cardiovascular circles, which one of these inhalers you can use, and the simple answer is both. Combivent. It's a combination of ipratropium and albuterol, and so even though it is a single canister, it contains two different drugs. So don't think of combination drugs as one drug. Think of them as two drugs, all right? Because sometimes I ask people to describe albuterol and they'll describe Combivent. I'm like, well, that's fine, but only one of the drugs in Combivent is the albuterol, the other one's ipratropium. Combivent as an inhaler is Combivent, and then when this is in combination in a breathing treatment in a nebulizer, we'll call that duo neb, duo as in two. Comba as in combination. That's where those words come from. And so this is a rapid-acting inhaler that we can use for acute asthma. All right, so again, it's very important that your patients are aware of this, and if we need to, we can write with a Sharpie or somehow label these so that the patient is aware that these can be used in acute exacerbations of asthma. HFA is not a drug. HFA is a propellant. It's what makes the canister under pressure and squirt the air out, squirt the medication out of the inhaler. And so you'll see some of them, they say HFA. HFA is not a drug, it's a propellant. MDI stands for inhaler, all right? And in the old days, the inhaler, it used to squirt out a pretty good dose of medication, and now through careful engineering and technology, the drug companies assure us that there is a very specific dose that comes out of that inhaler, and that's great if you're an engineer. That's where MDI comes from. That's why they like to call them MDIs rather than inhaler. I think there used to be a Mid-Ohio Diagnostic Institute, so that's always what I think of when I hear MDI. And so MDI, that just means inhaler, and they will tell you that it means there's this specific dose coming out of the inhaler. Well, that specific dose is of no use if it hits the back of your wall and you swallow it. Maybe if you're trying to swallow the medication for very specific gastrointestinal disorders, that might be of use. But the main problem with using these inhalers is people squirt the back of their mouth, the medication never goes to the lung. So first of all, we have a problem where they don't know how to use, they don't know which medication is used for which, and then the other problem is they don't know how to properly use an inhaler. And so the easiest way to properly use an inhaler is this right here, a spacer. By using a spacer, we can put the medication into the chamber and then inhale from the chamber so the medication is not just squirting out of the inhaler to the back of our mouth. And so kids need chambers. It's called a spacer or an aero chamber. Adults that are just learning definitely need a spacer. People who are very dependent on their medications, they need spacers. And spacering is the best way to use an inhaler. But it's large and cumbersome, and so most people just use the inhaler. And the best way, the only way, to prevent them from just squirting the back of their throat and letting that metered dose they've so carefully engineered just hit the back of the mouth and be of no use, is you have them exhale a normal breath, and then while they're inhaling, they have their lips wrapped around the opening of the inhaler, and as they're inhaling, about mid-cycle of the breath, they click the inhaler and then continue to inhale so the medication is able to go all the way down. So again, you have them breathe out, and while they're inhaling, basically before the mid-cycle, you have them click the inhaler while they're inhaling so the medication can go to the lungs and actually touch the surfaces of the lungs. And so again, that's my problem with the use of metered dose. Well, yeah, you have this precise dose coming from here, and then you have all sorts of variables that are preventing the metered dose from actually going to the lungs. And so this is what a spacer is, and this is essential for the proper management of asthma with people who are new at using inhalers. People at home can also use a nebulizer. This is the same thing we do in the hospital, although we'd have, in the hospital we can deliver oxygen through the system. But the main difference is this has saline in it as well, and the saline can loosen up the phlegm. And so here we have ipratropium and albuterol as a breathing treatment, and it's called DuoNeb when we do that. And so this is nebulizer treatment. We can use this to deliver oxygen. The saline is a mucolytic, breaking down mucus, loosening it up so we can cough it up through pulmonary toilet. We can deliver something called racemic epinephrine. Racemic means it's a mixture of the left-handed and the right-handed versions, because if we gave them pure L epinephrine, we'd have a lot of cardiovascular effects. And so they mix it with the right-handed version, which kind of blocks the effects of the left-handed version. That's why it's called racemic. Bottom line, kids who have a status asthmaticus in the emergency room, we will give them epinephrine, a sympathomimetic bronchodilator. And again, ipratropium and albuterol are bronchodilators as well. And so we can use this at home, same thing that we can do in the hospital. And so that's the most important thing we can teach an asthmatic, which inhaler is used for quick relief of cough and wheezing. Many inhalers must never be used during acute bronchospasm because they'll make cough and wheezing worse. And so this is Advair. This is a very popular use inhaler, but it's a maintenance inhaler, and so we don't want to use it for coughing and wheezing. These have little pills in them, and the pills in the machine are broken into a powder, and then the patient inhales that, and that powder goes to the lungs and treats the lungs for its inflammation. Yeah, the slide's coming up. So let's talk about the long-acting maintenance inhalers, and we'll start with the glucocorticoids. All right, glucocorticoids are the most important treatment of chronic airway inflammation. Remember, this is an inflammatory disease, and so for years we'd give them an albuterol inhaler because it made them feel better and opened their lung airways, but it never treated the inflammation. And somewhere 30 years ago, we realized that asthmatics were dying sooner because we weren't doing anything about the inflammation. And so that's why we use glucocorticoids, because failure to treat the underlying inflammatory condition will really result in premature death. And so that's why glucocorticoids are essential in the treatment of asthma. And so one inhaler you can use to rescue, but the other one we have to use as maintenance to actually treat the inflammatory condition. And there's all sorts of inhaled corticosteroids out there, and I'll let you guys take a look at that. But it's always important to deliver the inhaler properly. You can use a spacer. And then the glucocorticoids can increase the risk of something called oral candidiasis, a yeast infection in the mouth. And so it's always important to rinse out the mouth after using any inhaler, especially the glucocorticoids. And so this is something they like to ask you on the board questions. All right, we can also use long-acting beta-2 agonists. I would avoid the abbreviations at all cost. Something to know about the beta-2 agonists is back when we realized that giving people a short-acting beta agonist and not treating the underlying inflammatory condition that caused them an increased risk of death, and so it was essential that we give them glucocorticoids. Well, a long time ago, we realized that using long-acting beta agonists created the same problem, if not worse. And so if you listen and read carefully, long-acting beta agonists, if they're used alone, can increase the risk of death in the patient because all we're doing is masking the symptoms. We're not actually treating the inflammation. And so the long-acting beta agonists should always be used in combination with a glucocorticoid, and that's what Advair is, a combination of a glucocorticoid and the long-acting beta agonist salmeterol. All right, salbutamol is another word, and you can write this in your notes. Salbutamol is the international word for albuterol. In the United States, we say albuterol. Everyone else in the world says salbutamol. And so you want to put that in your notes under the rapid-acting inhalers, that salbutamol is albuterol. Albuterol, United States, salbutamol, everywhere else. Please do not confuse salbuterol with salmeterol, the long-acting beta agonist, because we see a lot of international people in the in Hawaii, and a lot of them use salbutamol, which is albuterol. All right. Well, when we realized that these were increasing the risk of death, we just want to take them off the market. The problem is that patients really like these medications. And so even though long-acting beta agonists used alone will increase the risk of death in an asthmatic patient used in combination with a glucocorticoid, Advair is one of the most popular medications used in asthma today. And I think the World Health Organization came out with a study saying if we could only have one drug in the treatment of asthma, it would be this right here. Sure, the risk of using this during an acute attack can make them worse, make that acute attack worse, but their thinking is if there was only one drug on earth to treat an asthmatic, they would want it to be this combination right here. Let's talk about the mast cell stabilizers. All right, the mast cells, remember, they release this epinephrine, they release histamine and leukotrienes, which make asthma worse. And so if we can prevent that from happening, then we can help control asthma, but we have to do it in advance. Once the horse has left the barn, it's no help to close the door. And so we can use mast cell stabilizers before we know something's going to bother them. So somebody's allergic to the horses at the fair, they know they're going to the fair, and maybe it's the grass. Well, they can use a mast cell stabilizer before to prevent histamine and leukotriene release. Especially useful in exercise-induced asthma. There are people who, when they exercise, for whatever reason, when they exercise, it causes an exacerbation of asthma. And so somebody who exercises and has exercise-induced asthma, mast cell stabilizers are especially useful for them. But again, we have to know in advance that we're going to have a problem for a mast cell stabilizer to be of any use. And most people that I've ever seen that have ever taken a mast cell stabilizer, they did not know that because no one took the time to explain that to them. Cromolyn sodium Intol is our mast cell stabilizer. Again, we want to use that about an hour in advance of a situation where we know there's going to be a problem. And then we'll talk about the leukotriene blockers. Again, remember leukotriene, especially leukotriene D4, is a mediator of allergic reactions. And so leukotriene D4 release by mast cells is a major problem for asthmatics, causing bronchoconstriction. And a very effective drug for the treatment of asthma is montelukast singulair. It's an excellent drug for asthma. We like to use this in children. Most children with asthma will outgrow it over time. And then there's some concern with a growing child with the use of a glucocorticoid, which can affect their anterior pituitary and its regulation of growth. And again, asthma is a chronic disease. So while the child is young, we're not too worried about the clinical manifestation, and so sometimes we can avoid glucocorticoids. We'll be more conservative about using glucocorticoids in a child, and we'll want to put them on Singulair. Singulair is very safe. It's been around a long time, and we can use it in children and adults as well. And so Singulair is a great adjunct to the other medications that we've talked about in the treatment of asthma. So again, the most important thing you can know about asthma, which ones are the short-acting beta agonists for quick relief, and then the maintenance drugs that prevent asthma attacks from occurring in the future. All right, that's more than enough for one day. When we come back, we're going to start talking about endocrinology, and then we'll start talking about immunology as well. So until then, aloha.